My name is Andrew Wasif. I'm a joint specialist out of Long Beach, California, Los Angeles area. The majority of the cases that I do are revision cases where there's larger pelvic voids and revision total knees where there's a little bit more bone loss. Well, I have a recent case with an 84-year-old male who came into me with a painful left total hip replacement, and he had a total hip done, several years prior to this, and didn't really have any issues with it. Was a pretty healthy guy, and began having pain and noticing a limp. And when he came to me, his radiographs showed a significant amount of osteolysis and polyethylene wear. As a standard preoperative workup, I always work everyone up for infection and did a pretty thorough workup, including aspiration and laboratory evaluation with ESR and CRPs, and everything was normal. So I made a surgical plan. I obtained a CT scan, and it showed a really unsupportive posterior column and an anterior column that was pretty much completely osteolytic. Well, intraoperatively, I established exactly what we were dealing with. A very thorough debridement was performed, as usual, for all these revision cases. At that point, I decided to make a custom tri-flange cage for him to restore function for him and give him some stability. At the time of surgery, intraoperative cultures were obtained, and it was actually found that he had a positive culture for enterococcus. Despite my pretty thorough workup preoperatively, sometimes that happens, unfortunately. I treat every revision as if it's infected anyway, and so I do a prophylactic treatment of local antibiotic therapy, and I try to clean out all of the soft tissue voids, so that way when I do use the stimulant, it is in a position where it can be useful and it can actually interact with the patient's bone. Stimulant plays multiple roles, but one large role is the filling of the voids. I think most surgeons that do enough revisions understand that a large void, A, structurally gives you problems, B, it really creates a situation where infection can take over, and so having something to fill the void is a very big benefit in those cases. Case turned out great, thankfully. After 6 weeks of IV antibiotics, it was discontinued. He never had any other antibiotic therapy. He's 9 months post-operatively. He's walking without any pain, and he's doing excellent. He has biologic fixation, well-fixed components, and he's doing really